Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith Rogers, and today we're bringing you an update on the public health response to devastating outbreaks of syphilis among tribal residents in the Great Plains region of the U.S. Dr. Meghan Curry O'Connell, Chief Public Health Officer of the Great Plains Tribal Leaders Health Board and a member of the Cherokee Nation, returns to the podcast to talk with me about the significant efforts to curb what was a 2,000% increase in transmission and what's happening now, particularly with deadly cases of congenital syphilis among infants. Let's listen. Dr. Meghan Curry O'Connell, welcome back to Public Health on Call. How are you doing?
Great. Thanks so much for having me back. It's good to see you.
It's been a minute, so it's actually been 18 months to be specific. We've had you on before to talk about this rise of syphilis cases that was occurring. So can you take us back to May 2020 and just kind of give us the lay of the land of what was happening then?
Sure. So back then, we had been addressing a large syphilis outbreak in the Great Plains area, which is North Dakota, South Dakota, Nebraska, and Iowa, that was concentrated among American Indian and Alaskan Native people. There's been a rise in syphilis cases nationally over the last several years, really for a while, but the cases really shot up around 2020 during the pandemic. And we'd been working to bring those cases down, but we're facing a lot of challenges related to having enough staff, having enough treatment, having the data that we needed to be able to go find people with syphilis and treat them. And so it was a challenging time, to be honest. There was a lot going on, and we were doing everything we could to try to address the syphilis outbreak.
And just to position your role in this as the Chief Public Health Officer, can you talk a little bit about the work that you were doing then?
Sure. So at that point, we, the Great Plains Tribal Leaders Health Board and the Great Plains Tribal Epicenter, which is essentially a consortium of the 18 tribal communities in that four-state region I mentioned, had been working diligently to find people with syphilis and get them treated. We had in 2023 the CDC come out for an EpiAid to help us with some of that. By 2024, they'd just come out again right before we talked last time to do some more work. And we were working with our partners, including the tribes, the states, and IHS to try to get more data so that we could figure out more details about the outbreak, figure out who has syphilis, how are we going to find them, and get them treated. And in February of 2024, the health board had also submitted a request to Secretary Becerra at the time, the HHS secretary, to declare a public health emergency to try to free up some resources and bring extra resources to this massive problem.
One of the things you mentioned in that episode is that outbreaks seem to be occurring in some populations that are different than what has traditionally happened in the past.
Yeah, so and that continues still today. So not just in our area, but nationally, American Indians and Alaska Natives have had the highest rates of syphilis during this outbreak and the highest rates of congenital syphilis, including rates of congenital syphilis that haven't been seen since the 1940s, when even before there was effective treatment in the form of benzathine penicillin. So that's one unique aspect of this outbreak is the very high rates among American Indians and Alaska Natives. But among that population specifically, there's actually a rather high proportion of women who have syphilis. So in recent years, the thought has been that the rates are highest in men who have sex with men, and that's been true historically. But in this particular outbreak among American and Alaska Natives, the transmission is primarily heterosexual, and so the rates among women and men are essentially equal. We've seen years where women might actually have a higher case rate than men, but they're pretty much equal. And that's very different, even in this syphilis outbreak nationally, compared to other racial and ethnic groups.
And at the time, you said it was like a 2,000% increase from baseline. So fast forward 18 months, where are we today?
Well, I'm happy to say we are doing much better. There are still too many syphilis cases, but the cases have come down significantly. We are still seeing the same disparities with American Indians having a higher rate, but the rate is coming down. Of course, we're partway through 2025, so we don't have all that data yet. But from 2023 and mid 2024, the last time we've talked, the rates seem to be going down significantly, which is great. So we're not out of the woods yet, and we have a lot of work to do, but it seems that all the work that everyone has put in is working and it's doing the right thing, and the syphilis cases are decreasing.
Can you give us a specific example of just how much these numbers have changed?
Sure. Let's look specifically at congenital syphilis. So, congenital syphilis is when a baby contracts syphilis from the mom during pregnancy. And it's a very, very serious disease. 10 to as much as 40% of babies infected with congenital syphilis die either before birth, as a stillbirth, or after birth. So it's a very, very serious disease that is entirely preventable if you treat the mom before delivery, which is pretty amazing. But there's been a huge increase with congenital syphilis cases in this country. Again, if you're having heterosexual transmission of syphilis, you're going to have babies that are infected with syphilis. And we've seen the rates of congenital syphilis come down. They lag a little bit behind the adult rates, so we haven't seen them drop as significantly as we have seen among the adults, but they are coming down. So just a couple of years ago, there were 54 cases of congenital syphilis in South Dakota, for example. And this year, South Dakota is on track to have approximately 30 cases. Now, that's still way too many cases of congenital syphilis, but it is a very significant drop. So these are babies that don't have to go in the NICU. These are babies that aren't dying. They're surviving. The pregnancy is being carried to term. And so that piece about congenital syphilis is very important when you're dealing with syphilis because it's so devastating to the babies, to the families, but it's also entirely preventable. So that's why it's so important to make sure that we're finding these adults who have syphilis, getting them treated, finding their sexual partners and treating them, because that is the best way to prevent congenital syphilis and prevent babies from being harmed.
Well, let's talk about that work. So I think there's a few different buckets that we can address this in. We can look at, the data visibility aspect and then the public health response. Let's start with the data. That was a big issue last time is not having this visibility. So where are we now?
So we've been working really hard. The team at the Great Plains Tribal Epicenter is amazing, and we have wonderful support by our tribes that run the epicenter throughout the region to get data. And they really supported and understand why public health data is needed to do public health work. It's very hard to do public health work if you don't have data. You don't know what's going on. You don't know who's sick. You don't know what the rates are. We've made some strides in that area. In the spring of 2024, we signed an agreement with the state of South Dakota to receive infectious disease data, which is great. That can help significantly. It goes to the tribes so that they can do case investigations or monitor what's going on in their communities. We've also been receiving more data from the Indian Health Service so that those people that are seen at IHS facilities, especially in states outside of South Dakota, can also receive that data and that they may not be able to receive other ways. So we've been working in a lot of different ways to get data flowing. There's some other data feeds that we've sought, and we're doing a lot to build our infrastructure to make sure that that information is available and accessible to all the tribes. But it's definitely in a much better place than we were back when we talked last time.
And now let's talk about the public health response. What's been happening there?
Yeah, so it's grown a lot by having data and starting to get access to data. That means that then the tribes and the Great Plains Tribal Epicenter can start to do more active response. Without data and knowing who's sick, for example, knowing who needs to be treated or tested for syphilis, it's very hard to go out and treat those people, right? But now that that's known, there's been a lot more ability by the tribes to go out and find people and treat them, working partners with the state to bring people in, do contact tracing. The Great Plains Tribal Epicenter has developed a disease intervention specialist training program for tribal partners so that they can train their staff to do that work and bring people to treatment, connect them to care. So having that data has really helped helped with the local capacity to do work because you can't do the work without the data.
There was another piece of this issue at the time that may still be lingering now, and that is the treatment aspect of it. Can you talk about the penicillin shortage?
So last time we talked, we were in the midst of a penicillin shortage, which I'm happy to say ended by the end of 2024. But unfortunately, we are in a new benzathine penicillin shortage that started this summer, so July of 2025, after a large recall by the manufacturer. We had a few months where there was not a penicillin shortage, which was great. And then one day we thought there was enough penicillin for the country, and the next day there was definitely not enough. And it essentially, Pfizer called it a near stock out, which means hardly any penicillin. And that is slowly improving. Pfizer started shipping limited benzathine penicillin early fall, late summer, but we're still in a pretty significant shortage, which can make it difficult because there is no other treatment than benzathine penicillin for people who are pregnant and infected with syphilis. And of course, treatment during pregnancy is the only way to prevent congenital syphilis, where a baby gets syphilis. But it's also the only recommended treatment for syphilis by the CDC. There are other treatments, but it is the preferred treatment. So we want to make sure everybody gets benzathine penicillin if we possibly can. Luckily, due to the prior shortage, I believe in early 2024, the FDA had approved the importation of benzathine penicillin from a couple of other countries. And that is available. And that has been extremely helpful, especially during this new shortage, to make sure that there is enough benzathine penicillin for pregnant people, first of all, but also that there may be enough that you can use benzathine penicillin for other people that have syphilis. And so the shortage is currently scheduled to end in Q3 of 2026, I believe, which is about a year from now. So we've still got a ways to go, and the importation is very helpful. And again, Pfizer is starting to release more as it's produced, but it's still going to be a while until we're out of this new shortage.
So this whole public health response takes resources. It takes people to do all of this contact tracing and finding people and helping them get treatment. It takes money. Penicillin is very expensive. Can you talk about some of the support you've gotten, particularly from the federal government during this time?
Yeah. So, as I mentioned, in February of 24, we at the health board, and by that I mean really the tribes, had asked the federal government to declare a public health emergency. That has never been declared. They declined to declare that public health emergency. However, the tribes had asked for some very specific resources to be released under the emergency, and a number of those have actually been done that have helped with the syphilis outbreak in our region. So, for example, one of the requests was that the public health service be mobilized to bring extra staff. I mean, we need people who can give shots of penicillin. We need people who can go out and find people who need to be treated. And so the public health service has been deployed a couple of times this year to the Indian Health Service, and they've worked throughout the region to try to do contact tracing, do testing, and give treatment to people, which has helped tremendously.
So this is really a good example of this day-to-day public health, boots on the ground response to a pretty devastating disease. And we've seen over the last 18 months, you said there's been significant reductions, but we still have a lot of work to do. Where do we go from here?
It's one of those things where we can't really take our foot off the gas, right? We can't let up. The numbers are definitely going in the right direction. And I am just amazed and so grateful for everybody that works on this. I mean, we are talking about a huge area of the country. We cover a 4-state region. We have 18 tribal communities. There's all these different jurisdictions. We work with local jurisdictions, tribal jurisdictions, states, federal, and everybody's been working together to try to address this outbreak. But we can't stop, right? We're not anywhere near where we want to be yet in terms of syphilis. Not that long ago, we thought we were going to eliminate syphilis from the United States. I'd love to see that. But at the very least, we want these numbers back where they were before the outbreak, and they're probably about 10 times higher than they should be still. So we need to continue these efforts, including things like regular screening, which Indian Health Service has recommended, annual screening for syphilis, and making sure people get treated. And really important, which is, we've improved a lot, but it's just very hard to do, is that contact tracing piece is extremely important, right? Once you know someone is infected with syphilis, interviewing them and finding their sexual contacts and making sure those people are treated and contact tracing from there, from those people that are positive, is really important. And there's no shortcuts there. It's labor intensive. It takes a lot of time. You've got to have people there to go do it, but it's probably the just basic public health thing, and that's the most important thing that we really need to continue to do to find the people that are most likely to be infected.
Well, Dr. Meghan Curry O'Connell, thank you for joining us again on Public Health on Call to give us, what sounds like so far a very positive story about this outbreak.
Yes, everything is going in the right direction, and I hope it can continue. And hopefully I can come back and say we've gotten the syphilis cases down to almost nothing. That would be great. So hopefully we'll be able to do that soon.
I look forward to that episode. Thank you so much.
Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.